Good morning. My name is Dr. Robert Groysman. I'm with covidinstitute.org. I'm also putting out the link for our private paid community called longcovidfamily.com. I wanted to do my usual disclaimer. I can't diagnose you and I can't provide a treatment or treatment suggestions through this kind of private forum. While we wait for questions to start rolling in, I wanted to talk a bit more about the six mechanisms that I look at for diagnostics and treatment of long COVID. The first one is dysautonomia, and that includes both the fight or flight response and vagus nerve dysfunction. Both of these can be caused by COVID and also by COVID vaccine injury. However, not in everyone. Then we have the mitochondrial dysfunction, and this is a problem with both energy generation, that is ATP, and is a problem with metabolic functions because you need energy to be able to metabolize products and things. Then we have the gut dysbiosis, and COVID directly damages the gut flora and can cause problems that way. That's another mechanism. Then we have endothelial dysfunction, and this is a problem with the lining of blood vessels. In particular, with long COVID, what we see is early on we'll have problems with the large blood vessels, and some people will experience heart attacks and strokes, and even a DVT, which is a deep vein thrombosis that can go into the lung, causing a pulmonary embolus. Later on, what we're seeing is small vessel disease, mainly affecting capillaries. And we see problems there, plus or minus with the microclots, but the issue is with delivery of oxygen to particular tissue. So in those cases, you'll see a normal blood oxygen level because you'll do a pulse oximeter and the oxygen concentration will be normal. And you still feel short of breath or you'll have air hunger. Fair? And next we'll have hormone imbalance, okay? Because COVID can mess with testosterone, progesterone, estrogen, and cortisol production, and also thyroid hormone. So if we're seeing a problem with hormones, again, it could be coming directly from the initial COVID insult. And we'll have MCAS and or histamine problems or histamine excess. MCAS is inappropriate degranulation of mast cells or mast cell activation syndrome. And this is not an increase in number of mast cells, but basically inappropriate discharge or degranulation of these mast cells. And they have a lot of components inside the mast cells that are fairly toxic and caustic. There's many digestive enzymes in there to basically break up any pathogens. Excess histamine can come from just failure to break it down or a decrease in metabolism of histamine. You can also have increased production of histamine that comes either directly from your gut because you have gut producing microbiome species that are producing the histamine or producing more histamine, or come from the outside, such as foods that either have more histamine in it, such as foods that are fermented. Anything with cheese, anything with fermented products like yogurt, sauerkraut, and even foods like wine, especially red wine. It's obviously fermented. Beer is fermented, so you may have more histamine in those products. Food that sits in your fridge can also show up with a lot of histamine in it. That's because the bacteria that are in the food, they're not necessarily pathologic, but they're in the food anyway, and they make histamine, and the longer it sits in the fridge, the more histamine you get. So that's another way for your body to get more histamine from just the foods you eat. Let's see, did I miss one? We got the mitochondrial dysfunction, we got endothelial, we got the MCAS. I know I'm missing one. Well, it'll come to me. We're starting to get some questions in, so I'm going to go ahead and jump in and start answering questions. Savannah asks, is an SGB something that could help MCAS symptoms? Let me put the question up. Here we go. The best way I can answer this is not directly. So what the SGB does, or stellate ganglion block does, is it temporarily disconnects the sympathetic pathways between your neck and your brain and the rest of your body. So these are the pathways that your brain uses to send the fight or flight response and also the support for the sympathetic side of your autonomic nervous system. So when the sympathetic side is active, and if it's overactive, it will activate your immune system. It will make it function harder. It'll make it more excited. And in that way, it can also make the mast cells degranulate as a trigger. So in a way, by shutting down the system or quieting down the system, you can also help MCAS indirectly. So yes. Next question we have is from C-Trader, talking about reactivated EBV, which stands for Epstein-Barr virus. And yes, it can happen from long COVID. What happens to somebody who has never previously had EBV and then gets it during long COVID? Is the effect the same or more serious? So Epstein-Barr virus is a herpes family virus. It's related to chickenpox, a varicella zoster virus. And once Epstein-Barr gets into your system, it is there for life. It doesn't always have to cause problems for life, but it is a part of your body for the rest of your life. And it causes a condition or infection called mononucleosis, kissing disease. It has a couple other names. Usually see this in children or young adults. It's passed through the oral route typically, and that's why it's called kissing disease. And it causes mononucleosis, which typically causes your glands under your neck to enlarge and become painful. These lymph nodes back here cause a sore throat. It can cause a fever. It can cause essentially symptoms of mono. So if you've never had Epstein-Barr virus, which is very unusual because most people have been exposed at some point in their lifetimes, it would show up pretty much like it does any other time. So the reason that we get reactivated Epstein-Barr virus during long COVID is because the immune system becomes dysregulated. Right? It's not necessarily suppressed. It just becomes dysregulated and doesn't function the way it's supposed to. So this can trigger a reactivation of Epstein-Barr virus. It's been suggested in the past that the reactivation of EBV could serve as a biomarker for long COVID, because we almost always see reactivation of Epstein-Barr in long COVID. I hope that answers your question. I don't expect it to be any more serious than getting mono any other time. Adults tend to have more problems with Epstein-Barr than younger folks, but it shouldn't technically be more serious. That's pretty much all I have to say about Epstein-Barr virus. So let's see here. We have a bunch more questions coming in. Here's a question from Jessica. Recommendations of excess mucus and phlegm production, as well as pain and inflammation in the lungs. So excess mucus, there's several different reasons for excess mucus and phlegm production. One is a disruption of the autonomic nervous system. We commonly call dysautonomia. The thickness of the mucus is controlled by how much vagus nerve versus sympathetic, or the basically sympathetic versus parasympathetic, is introduced or is active. Okay. Pain in the lungs, I'm not sure what you mean by, like, it hurts to take a deep breath, it hurts in your throat. I'm not really sure what you mean by pain and inflammation of the lungs. Does it show up on MRI? Is there edema in the lungs? I'm not really sure what you're really asking about the pain and inflammation of the lungs, so I'm not really sure how to answer. I'm sorry. If you want to clarify, I'll try to go back. I'm going to go ahead and go to Linda's question. How do I know if I have long COVID? Okay, let's stop there for a second, Linda, and let me answer that for you. So it's one of those things that you kind of know when you have it, okay? So there's no diagnostic test you can take, no blood work, no imaging, really nothing you can do to say, yes, I have long COVID, or no, I don't have long COVID, okay? It's a clinical diagnosis. There are over 200 symptoms. Essentially, if you have new symptoms or basically continuing symptoms from when you had the virus and it doesn't go away within 3 months, or new symptoms are starting at 3 months and continue and last at least 4 weeks or longer, chances are you have long COVID. Common symptoms that we look for in long COVID are the brain fog, the chronic fatigue, the anxiety. Some people have cough. Some people have joint pains and aches. Some people even have fevers that have no other explanation. There's just so many different symptoms that you can look at from long COVID, including post-exertional malaise, exercise intolerance, gut problems like nausea or bloating, different rashes, your hands or your feet or your toes and fingers turning red or white or purple. So there's just so many different things that could potentially represent long COVID, but it is a clinical diagnosis. That means somebody is aware of long COVID and can put these symptoms together and identify it for you, or you can do this yourself. So having the virus twice and being vaccinated doesn't change, I guess, the risk for long COVID per se. So having the virus, that is the COVID virus, the SARS-CoV-2 virus that we're talking about here, can, of course, put you at risk for developing long COVID. But unless you have the pre-existing risks already, you won't necessarily develop it just by having the virus. And the same thing is true for vaccination, COVID vaccination. Some people develop a COVID vaccine injury because the spike protein that is used as an antigen, that is to induce our immune system to produce antibodies to, is biologically active. In all other vaccines that we have, the antigen that's used is biologically inert. So it's kind of there and you make antibodies to it, but it doesn't actually do anything. But the spike protein that's produced by the mRNA is biologically active, which means it can interact with our receptors and our bodies and our cells, and it has some effects. And in some people who are at risk, they can develop a COVID vaccine injury. So the sense of smell and taste is pretty much kind of pathognomonic for long COVID. It doesn't typically occur in other forms of post-viral syndromes. The horrible fatigue, as you said, changes in thyroid is common because COVID and or the spike can potentially interact with your thyroid, can alter how thyroid hormone is made. And vision has multiple different causes. It could be the autonomic nervous system. It could be the mitochondria and the eye muscles. There's a lot of different things, including endothelial dysfunction that can cause vision problems. Cholesterol, if it's high, can be part of a metabolic problem that we see in long COVID. I typically attribute this to mitochondrial dysfunction. And it's usually accompanied with also high blood sugar, weight gain, other things that come up with a metabolic syndrome. I hope that answers your question. Will has a question. Can endothelial dysfunction cause itching and face flushing, or should that be treated separately as MCAS? That's a great question, Will. So itching and face flushing, I would attribute more to a histamine issue. However, face flushing can also be a result of dysautonomia. Blood flow and where it goes, especially in the skin, is typically controlled by your autonomic nervous system. So when the sympathetic nervous system activates, it can cause your face to flush. It typically won't cause it to itch. It'll cause it to flush and become red, like from embarrassment, as an example. But it shouldn't cause it to itch. So I wouldn't really even consider endothelial dysfunction in this kind of scenario. I would mainly be looking at histamine related, and it doesn't necessarily have to be MCAS. So remember, MCAS is a mast cell activation syndrome. So you don't have to have MCAS to have excess histamine present in your body. As I mentioned earlier in this podcast, you can accumulate histamine due to a problem with metabolizing it, that is getting rid of it. You can have a problem with it being formed in your gut, so you get excess that way. And that happens from histamine producing gut flora. And you can also have excess coming in through your foods and drink. Okay, well, Marianne is asking about studies and investigate risks of developing new symptoms if you have long COVID and then get reinfected. So the issue with different symptoms, new symptoms coming and going, is that there are 6 mechanisms involved with long COVID. Now, no one mechanism can explain long COVID. So every single person who has long COVID has at least 2 or more of these mechanisms involved. Their interaction. So these mechanisms are not standalone, like working on their own in isolation. They interact with each other. And that can cause waxing and waning of symptoms. Okay, there's also triggers that make some of the mechanisms worse or even better, depending on what you're doing. So the symptoms are really just a function of each of the mechanisms that are involved in each person. And developing new symptoms just means that you have a different interaction between these mechanisms, or you have a new mechanism introduced. And mechanisms can shift. You can have an autonomic nervous system problem, and you can have a mitochondrial problem, but then develop a gut dysbiosis problem on top of that. Okay? So that's really what's responsible for all the confusion with the symptoms, developing new ones, losing old ones, and the shift between them. Tarn 72 is asking about SGB, which is stellate ganglion block. Does it help noise and light sensitivity that causes PEM crashes? Well, let me first address that. So noise and light sensitivity typically occurs due to dysautonomia. This is a direct result of being in fight or flight. Okay, you have an increased perception. Your senses are increased. Okay, just like your reflexes are increased, your senses are increased to sound and to light as part of the fight or flight. PEM and crashes, I kind of put into the same category because I find them to be the same, is a result of a mitochondrial problem typically. And this has to do with not having a filled battery bank. So normally during at night, during deep sleep, you will recharge your battery banks with energy because you've used it up during the day, and you're not typically generating new energy during the day. That happens mostly at night. You have these stores and you use them up during the day, and then you clean everything out and recharge at night. And that's where deep sleep comes in. So I can see that noise and light being a trigger for you, but they're typically caused by 2 different mechanisms. So that goes to you, the next part, second part of your question, which is attends with NeoClip has been helping my noise sensitivity, and that makes sense because when you increase vagus nerve activity and tone, you are decreasing sympathetic or the fight or flight activity. So that would make sense why it would help with your noise sensitivity. I hope that answers your question, Tarn. Angela is asking about MCAS. Do I find ketotofen better for MCAS rather than just regular H1, H2 antihistamines? It's not really better. It's an adjunct. So if you're having high histamine levels, regardless if it's from MCAS or just having excess histamine in your system, we have 4 different histamine receptors in our bodies. We usually focus on the first 2, the H1 and the H2. H2, as you know, focuses mostly on the gut and production of acid and things like that. H1 focuses on the nervous system and the brain, and it's one of the neurotransmitters, the histamine in our brain, that helps keeps us awake, and that is why H1 blockers or H1 antagonists make you sleepy. So ketotofen is a great mast cell stabilizer. So that's kind of what I use it for mainly. If I suspect more on the MCAS side than on the excess histamine side, ketotofen is useful to stabilize mast cells. I hope that answers your question, Angela. Looks like we have another question from Tarn. Are you able to do much for patients over telehealth, particularly for CFS? I'm in Australia. Well, congratulations. I'm assuming it's nighttime there, right? In Australia right now, because you guys are so far ahead of us. Yes, I can do plenty over telehealth. What I can't do over telehealth is treat you with a stellate ganglion block or an EAT procedure, or perform some of the tests that I do in my office. But remember, I said there's 6 mechanisms. So there are many things we can do for the other mechanisms. However, what I find is that if you're stuck in fight or flight, that really needs to be addressed first, because it really prevents you from healing. So if you're stuck in survival mode, okay, which is what fight or flight does, you're stuck in survival mode. It's perceived danger all the time, perceived fear of death. Your body is going to put all of its resources towards survival, okay? It's not going to spend any time on healing, repair, maintenance. And you need those functions to be available if you're going to heal from long COVID, if you're going to heal from anything. So that needs to be reversed first, however you do it. What I find to be most effective, as I said, would be the stellate ganglion block procedure and the EAT procedure, epipharyngeal abrasive therapy that I do. You can also do vagus nerve stimulation, but really that needs to be addressed first if you have it, before you can treat the other mechanisms. Of course, you can certainly try treating the other mechanisms first, but like I said, many of the time that I've seen is you need to treat the fight or flight first. Thanks. C Trader asks if there's an objective blood test for endothelia. So I'm assuming you mean endothelial dysfunction. Yes, there are some markers, but I don't know if you would consider them definitive. So I look for basically inflammatory reactions. I look at high sensitivity CRP, for instance, C-reactive protein. I look at interleukin 6. Those tend to be elevated, but not excessively. They are slightly elevated if you have endothelial dysfunction. You can look at VEGF as a marker of vascular dysfunction. I mean, like I said, nothing is really like 100% definitive that you look at it and you could definitely say this is endothelial dysfunction. What I do is I do a nail fold test that I'm looking at the capillaries in your nail fold to see if there's damage to your vascular structure. So chances are if you have damage in your capillaries here, you're going to have damage in your brain, heart, lungs, and other areas. So that tells me more directly that there is an endothelial dysfunction problem. Here's a question from Jessica. I have dysphonia now with long COVID. I'm assuming you're asking, why do I have dysphonia? So dysphonia is an abnormality in your voice, and the vagus nerve is mostly responsible for controlling your vocal cords. There are several nerves that come off the vagus nerve, one of them being the recurrent laryngeal nerve that helps control your vocal cords. So since COVID can damage the vagus nerve, we do see vagus nerve dysfunction fairly commonly in long COVID. So again, those two procedures that I mentioned earlier, which is the stellar ganglion block procedure and the ETH procedure, epipharyngeal abrasive therapy, are useful to help with dysphonia. You can also try vagus nerve stimulation to help some. Thez Cold is asking, if one can't come to you, will you teach other doctors soon, like Sweden and Norway or Europe? Yes, my plan is to eventually teach other doctors. I'm working on a curriculum to be able to teach other doctors. Um, it's also going to be up to these doctors to want to learn about this or the way I do things. And not everyone does, but those that do and want to come and see me or take my classes and courses with me, I'll be glad to teach them. Will asks, is viral persistence a factor with vaccine injury? So let's kind of go over what viral persistence really means. So the COVID vaccines do not have any virus in there, correct? They have modified mRNA, which is what the M stands for, in mRNA COVID vaccines, not messenger RNA, which is what it typically means, but in the vaccines it means modified, and it codes for a spike protein. Okay, and the purpose of the spike protein is to get your immune system to make antibodies to it and reduce the risk for severe problems and symptoms from COVID. However, in some people, this mRNA and the spike protein is not cleared out. Okay, so it basically lingers inside cells for prolonged periods of time, and this is what is meant by viral persistence. Okay, so there's no live virus, there's no active virus, there's nothing replicating, but in some people, this mRNA either continues to generate or translate into spike protein, or the spike protein persists longer than expected and is not destroyed after your immune system has seen it, and that can lead to basically COVID vaccine injury type situation in those who are at risk or susceptible. So Maraviroc is a CCR5 blocker, and it's mainly used as an antiviral for HIV. And again, something like this, any antiviral, really only works for replicating virus. So it either stops a virus from entering a cell to replicate, or it prevents its replication when it is already inside the cell. If there's no active replication of virus or viral DNA, then Maraviroc really won't be all that helpful. I guess there are some effects from the actual anti-inflammatory feature of it, but I wouldn't think it would be helpful necessarily post-vaccine or for vaccine-related symptoms. So people who are more susceptible to injury, like I said, they tend to produce more spike protein, so they have a higher load, or their spike is not degraded when it should be, or they persist to have this mRNA continually produce spike protein longer than anticipated or desired. M. Marcotte, hope I pronounced your name okay. Which treatment is best for extreme fatigue? ENT, SGB, or a combo? Well, you have to go back to what is causing the extreme fatigue. Most of the time, I see fatigue associated with mitochondrial dysfunction. However, it's useful to know if the fatigue is all the time or if it's triggered or made worse, for instance, with activity. That would be either physical activity or brain or cognitive activity. If so, it would point more towards mitochondrial. However, fatigue can also be caused by dysautonomia, and that has to do with changes in blood flow that occur during a chronic fight or flight state. Okay, again, we're working on survival here, not on solving complex equations and problems and doing physical work per se. Um, you can also have fatigue caused by other problems, and endothelial dysfunction can cause it in the brain. You can also see it from gut dysbiosis due to release of LPS, which is lipopolysaccharide, and that is a part of your bacterial wall that's in the gut flora that gets released due to leaky gut into the bloodstream and gets into your brain. That can cause fatigue. And basically, any of the mechanisms can cause fatigue, including histamine and MCAS, including hormonal problems like low testosterone, low estrogen. Um, I'm not sure what you mean by ENT, like ear, nose, throat doctor, go to visit. I'm not really sure kind of where you're going with this because I'm not sure what they would be able to do for this, unless you're talking about the EAT procedure, maybe. So EAT and SGB would both target fatigue from the dysautonomia and vagus nerve involvement, okay, and chronic inflammation, because what happens after you've had COVID is some of it settles in your throat. I'm not talking about live virus here or anything, but you can have pieces of viruses, pieces of viral components that are continuing to generate interleukins and cytokines. And remember, they're hidden behind a layer of mucus and perhaps even a biofilm that a bacteria had set up there. And it's really not accessible to your body. So the IgA that is normally produced in the back of your nose and throat, it's really decreased. Okay, so you're not able to protect from additional infections or to even target this one. Okay, so basically it's a chronic source of inflammation that's in the back of your nose and throat. Even if you don't have a nose or throat problem, it can still be there. So yes, in that case, I would probably say combo would be the desirable way to attack that. Skyly is asking about a microcurrent system designed for pain management and tissue repair. Would it help in long COVID? So there's different purposes for these stimulator devices, okay? For the purposes of vagus nerve stimulation or trigeminal nerve stimulation, our goal is to actually stimulate the nerve. And there's a threshold you need to meet. Microcurrent typically won't get to the threshold that we need to activate this nerve. And the microcurrent system, as you said, is meant for pain management, and it has a different purpose. So if you're using it for pain, I guess it's okay, but it won't really stimulate the vagus nerve, really any nerve. It doesn't have enough of a threshold to be able to do that since it's in the microamperes range. C Trader asks, if long COVID patient gets a GI map test, and this is a stool test that looks at what bacteria is coming out in your stool. So it gives us somewhat of an indication of what is actually going on in your gut flora. Test for the microbial and bacterial populations in the gut. Do you think it makes sense to try to tailor probiotics to specific strains where deficient? So what I typically see, and yes, I do use the GI map or similar stool test companies to look at what's going on. But what I'm finding is for the most part, butyrate producing species are low. I often see lactobacillus species low, and occasionally see bifidobacterium species low. So what I typically try to target when I treat my patients with probiotics is those particular species, because it's pretty unusual to see pathologic species move in. What you can see is increase in histamine producing species in some folks, because as you decrease one population species, another one takes its place. So yes, you can get a map if you want to. They're not absolutely necessary, but if you want to, you can. You can also look for zonulin in some of these tests. If you have an increase in zonulin in the stool, that gives you an indication you may have leaky gut. Can I talk about the role of inflammation and the tests? Tom asks. What else would I look at other than CRP? Um, I mean, prostaglandin can be used as a measure of inflammation. I tend to use prostaglandin as a measure, for instance, of mast cell degranulation, but I look for it in the urine too, not just the blood. You can look at ESR, um, which um, which is a more generalized way of looking at inflammation. Now remember, inflammation, unless it's in your entire body, may not be picked up by these tests. If it's locked away in an abscess or locked away in a particular part of your body, for instance, it may not show up on these blood tests. Um, interleukin 1, interleukin 6 are useful to show inflammation as well. Okay. Yes, there's many other cytokines and interleukins you could look for, but they all kind of point to the same thing and will show inflammation if it's there, if it's body wide. Okay. It may not show up if it's really low level inflammation though, Tom. Okay. CW asks, can the TENS unit pads be placed on the neck to stimulate the vagus nerve? The answer to that is yes, but you have to understand that stimulating the vagus nerve on the neck really stimulates the peripheral vagus nerve. So most people can't tolerate more than a few minutes of stimulating the vagus nerve at the neck, which is why I prefer the ear, because you can stimulate it for 30 minutes or an hour, and you shouldn't really have any problems doing it that long. The issues I look with stimulating the vagus nerve and the neck, and again, that's assuming you're actually stimulating the vagus nerve. So, I mean, the way to identify it is to find the carotid, which would be finding the pulse and then just going slightly behind it, okay? And you want to be about in the middle of your neck between the jaw and the clavicle, okay? So roughly in the middle part of your neck is where you want to put the pads. However, as I said, you're more likely to get bradycardia, which is slowing of your heart rate. You're more likely to have increased gastric activity, which means your stomach may churn. You may start producing acid. You may even get nauseated from this. You may start producing more saliva. All of these are vagus effects, okay? And there's others, obviously, that you may see, but most people can't tolerate stimulating the vagus nerve, actually stimulating it, not just putting pads on, not just vibrating it or beating it or touching it, but actually stimulating it for more than a couple of minutes due to this. So the answer to your question is yes, you can, but it's really limited to how long you can do it. And also make sure the settings are proper, because you can injure the vagus nerve, okay, if you overstimulate it. You're welcome, Jessica. Thank you, Angela. Fez is asking, what should one do if coming to you seems impossible? Other doctors who do EAT or HGB in the UK, for example. Um, I mean, I don't really have a good answer for you. I would still start with a consult, because at least we can come up with options. But Yes, you can get the, SGB other places. It's not going to be the same as mine, but it may work. It may not. Um, the reason mine are different is because I've done so many. I've developed my own technique, and it's really kind of a different technique from other doctors. It's not to say that other doctors can't do the stellate ganglion block. Of course they can. This is something that pretty much every pain doctor learns to do when they go through training. However, there are differences that can be introduced. I'm not talking about what I put in. I'm talking about where it's injected, and each person is slightly different. Okay, there's a lot of variation in anatomy. um, as far as eat, if you don't want to come see me, you're going to have to go to Japan because that's really the only place where you're going to be able to get it. I mean, if you're in Australia, um, maybe Japan is an option. From the UK, I don't know. I don't know how far Japan is from the UK compared to the US. But I'm also making changes to the procedure to improve it and make it better. That is not being done in Japan. In Japan, they've done it the same identical way for the last 70 years, since the 1960s, and I'm trying to make improvements to it. I'm trying to build a better mousetrap to get better results. Okay. Kylum8117 is asking, what if SGB failed 3 times and doctors found enteritis and abdominal wall thickening on, I'm thinking that's what you mean, on CT scan? Then could viral persistence and some inflammatory cascade be the root? How would you treat enteritis? Well, I mean, those are not connected. Um, when you say SGB failed 3 times, are you talking about you've had it 3 times on both sides done or on one side done? Was it a dual level? Was it a single level? Who did it for you? So I'm not sure what you mean by failed, except that it didn't work. Fair? I'm thinking you mean it didn't work. As far as enteritis, so I'm assuming you mean inflammation either in your small bowel or your large bowel, like colitis, or I'm not sure exactly what you mean. Abdominal wall thickening, again, are we talking about the muscle, or are we talking about the omentum, that's the fatty layer that goes over your intestines? I don't think either of these really kind of point to viral persistence, or even inflammatory problem. I would look for what's going on. Are you having gastrointestinal problems? Are you having bloating? Are you having abdominal pain? Are you having diarrhea, constipation? Are you having acid reflux? Are there really signs of bowel inflammation? Are you seeing blood in your stool? I mean, that those would be more useful to me to identify enteritis than looking at a CAT scan. What a CAT scan could be useful for instance, is to see a blockage. For instance, if you have intestinal blockage or ischemia, if a piece of bowel is dying, that's really dangerous. But outside of that, I'm not sure what other use it would be for me. You can also look for diverticulosis or diverticulitis, on CAT scans. Jessica, is vaccine shedding a concern with mRNA shots? Absolutely not. Okay, you cannot shed a protein. Okay, the only shedding that applies to vaccines are where the vaccines are live. Okay, back in the day, polio vaccine used to be live. You used to take it orally. It was a live vaccine, and yes, since it is a live virus, you will shed virus. Okay, that is really the only thing you can shed is virus. There's also used to be a varicella zoster vaccine for chickenpox that was also live and that was injected. And again, you actually broke out in chickenpox a little bit and you shed live virus. So the only way to shed live virus is to have live virus. Okay, you can't shed a protein. There's really no way for there's no mechanism built in for that to ever happen. Um, so because the COVID vaccines are not live, whether it's an mRNA or it's an antigen like the old J&J one, you can't really expel it out of your body per se, out of your body fluids, okay? In order to pass it into the air to give it to somebody else. So that's a really kind of a big farce and absolutely untrue, okay? C Trader 09 asks, do you? And yes, I do. C Trader asks, do you think people who fully recover from long COVID could relapse in the future? What can we do to reduce this risk? Yes, even if you fully recover, the original risk, what made you susceptible to long COVID in the first place, is still there. Whatever changes in your body that you have, and those typically are referring to prior damage to your autonomic nervous system or vagus nerve. And that can happen with various other conditions, and it could be completely preclinical, that is, or subclinical. You don't have any symptoms from it, but you still have it. It's a little defect. You never know it. If COVID never existed, you probably would have never known it for the rest of your life. You'd have lived your whole life and never realized that there was a little defect in there. Or there's a mitochondrial defect. Again, could be completely subclinical. You never would have known it. If we didn't have COVID or the COVID vaccines. So the same risk that you had when you got long COVID in the first place still exists. Okay, so yes, you have a chance of relapse in the future if you get sick again, and it doesn't even have to be COVID. It could be any virus. It could be a respiratory virus. Some people get relapses from getting anesthesia, or a surgical stress, or another kinds of stress. Okay, so all these things can increase your risk. How do you reduce the risk? Well, strengthen your parasympathetic nervous system. Vagus nerve stimulation is one way. Okay, you could do vagus nerve stimulation. I recommend this to everybody who has had a procedure with me, to basically continue vagus nerve stimulation, because you're going to increase your repair mechanisms that hopefully will make you more resistant to getting long COVID. And I've actually demonstrated this in several of my patients. They have even gotten COVID again and did not develop long COVID. Here's a question from Will. Could lactoferrin PEA and Singulair help histamine excess related symptoms in someone that didn't get relief with ketotofen, famotidine, or over-the-counter histamines like Zyrtec? So the first question I would ask is, how often were you taking the antihistamines? Lactoferrin I typically use for gut-related health to help stabilize the gut barrier and to reduce leaky gut. Okay, PEA is great for brain and for membranes. Okay, and Singulair can be an adjunct to helping with mast cell degranulation or MCAS, but it's not a sole or primary mechanism for treating it. So if you're not seeing results with ketotofen, H2 blockers, or H1 blockers together, then it's unlikely to be histamine related. Okay, unless you're only taking it like once a day or something, in which case it could still be histamine related. You're just not taking it often enough to see a difference. Scott and Kay, hi guys. What is the best treatment for PEM, post-exertional malaise, and how long does it normally last after your treatments? So the best treatment for PEM is to avoid getting PEM. In other words, don't push your body to a point where you crash. Okay, and that's knowing your body and knowing yourself, and trying not to do the activity to a point where you are developing PEM. Okay, PEM doesn't typically develop after my treatments, and if we're talking about stellate ganglion block and an EAT procedure, that's the epipharyngeal abrasive therapy. So some people have significant exhaustion post procedures, and let me explain to you why. If you're stuck in fight flight, you are not able to go into deep sleep. And deep sleep is where we're talking about stage 3 delta wave based sleep. Okay, this is the most important sleep out of all the cycles that you have in your body. Okay, even more important than REM sleep. And this is when your body spends all of its resources cleaning out all your waste. Okay, because you accumulate a bunch of waste in your brain, glutamate, okay, the amyloid proteins. There's a lot of stuff that kind of accumulates in your brain that your body can't spend time cleaning out during the day. It waits until deep sleep to clean it out, okay, and it shunts it to the cerebral spinal fluid, and it's gotten rid of your body and metabolized, okay. You're also doing maintenance, okay, so all the things that normally you can't do during the day because your body's busy doing other things since you're awake. You're doing it during this time during deep sleep, and maintenance and repair and all the stuff happens during deep sleep, including the the restful part of basically getting your brain ready for the next day. Okay, this does not happen if you're stuck in fight flight. Okay, you're just experiencing mostly light sleep or mostly awake. Okay, even if you're unconscious, even if you think you're sleeping well, you most likely are not. Okay, and your body keeps track of deep sleep. You still need to make up all that repair and waste removal and everything else. Okay, your body just doesn't forgive it and forget about it. You still need to do this. So post procedure, once you're able to do it, your body's got to take full advantage of it. Okay, and it's not just going to do it during deep sleep, which now you're getting, whereas before you weren't. It's going to also do it during the day as much as it can. Okay, and you feel exhausted because your body is not focusing on function here. It's focusing on repair, waste removal, and maintenance. Okay, all the stuff that's been neglected for weeks, for months, for maybe even years. Okay, so that's why it takes a while before you start feeling better, because all that gunk has to be cleaned out and repaired and cleaned out. Okay. I am looking for our next question here. We have a couple of statements. Timmy is asking, what do I recommend for gut dysbiosis? I mean, my treatments typically focus on two different parameters. The first is to reduce leaky gut, okay? Because that is responsible for some of the symptoms that are going on, because some of the toxins produced inside your gut can get into the bloodstream or even through the vagus nerve and get into your brain, causing some of the symptoms. The second part of gut dysbiosis is treating the dysbiosis itself, and that's the flora. Okay, and as I mentioned earlier, the top two things I see is decrease in butyrate producing species. And butyrate is very important, not just to stabilize the colon gut barrier. Okay, it's used for food there. It's a short chain fatty acid. But it's also useful to decrease activation of your immune system. So it keeps kind of things in check. It also helps with microglia in the brain by decreasing activation or excitement of your microglia in the brain and central nervous system. So my treatment basically focuses on these parameters. Okay, and it's a little different in each person. It really depends on their particular circumstances, their sensitivities, their other medical problems, or other medications and supplements they take. Okay, so I can't give you specifics here. Tanya is asking about tests for endothelial and mitochondrial dysfunction. So the tests for endothelial, I mainly focus on looking for inflammatory markers such as IL-6 and HS-CRP, which is high sensitivity C-reactive protein. I may check, for instance, for fibrinogen or homocysteine, because both of those can change if there's an endothelial problem. For mitochondrial problem, I focus on lactate and pyruvate, okay? Because if you have low reserves of energy, you're more likely to shift to lactate production, which is part of our anaerobic metabolic system, okay? You're generating 18 times less ATP for every molecule of glucose, going through anaerobic metabolism, but your lactate levels may increase just a little bit or significantly. But I also order a test called the O test, organic acid test. It's a urine test, and it's helpful to know if there's a problem with the Krebs cycle or glycolysis, which is basically the breakdown of glucose into pyruvate, and we can see where the blockade is, and then I can tailor the therapy to where the specific blockade is or the problem is. Sometimes it's just hypometabolism, okay? And you'll see just basically a slowdown in metabolism, but nothing is elevated. So it really kind of depends on what the tests show, and from blood work, that's pretty much all I do. Okay, I mean, certainly you can look at things like mitoswab, which is an oral buccal swab that you basically swab and send it into a lab. That can give you a bit of information on your electron transport chain. Some people do have a problem with that. It's also a mechanism part of the mitochondria. But otherwise, we're basically trying to decrease the oxidant levels in the blood because chronic stress, chronic disease causes oxidative stress. We're trying to support the mitochondria, okay, by giving them things so they don't have to make it from scratch, okay, and then working on some of the mitophagy and the biogenesis, which is my step 2, okay. So that's in general how I deal with mitochondria. Will I ever travel to other country for one, if we're willing to pay for traveling, hotel. If not, able to come see you. I really need the help and the treatment. So my goal is to eventually train other doctors in other countries. Um, it's a very labor intensive process though. Basically setting up a program and then either going there or having doctors come see me. Anytime I leave my office though, the issue is that the patients who depend on me here or come to see me are not able to be treated or cared for. So outside of even the expense of me leaving my office and going, flying somewhere else and paying for the flight and for the hotel and where would I, actually practice? I would need an office somewhere. And, do I bring my equipment with me? You see, there's a lot of logistical things, and I also need to bring some help. I need to bring a nurse or somebody to come with me to help with patient care. I can't do this by myself. So logistically, it's very difficult for me to travel somewhere else. I mean, some people are asking me to even get another office in Texas, so that they'll make it easier for them to get treatment that way. And I am considering it. Um, it's hard though. It really is hard because anytime I'm not present in my current office, I can't help the people who need me here. Kelly is asking, what do you consider optimal levels for estrogen, progesterone, testosterone in women? The best way I can answer this question is the level where you're not symptomatic. Okay, when I replace these, my goal is to get you to where you were when you're 20 to 25. Okay, a lot of people think that estrogen is a women-only hormone and testosterone is a men-only hormone, but that's absolutely not true. Men need estrogen and women need testosterone. Aside from the postmenopausal symptoms that low estrogen causes, okay, or no estrogen causes, is the protection. So if you don't have the estrogen floating around, and what we're talking about is 17 beta estradiol, okay, not the other estrogens that you find in birth control pills or pregnant mares, okay. I'm talking about specifically 17 beta estradiol, which is bioidentical. But what it does is it protects your brain from Alzheimer's, okay? That's been shown. So the amount of Alzheimer's we see in women postmenopausally goes up compared to before menopause. Protection from heart attacks and strokes, Okay, yes, estrogen does not make your blood clot. Okay, it actually protects you um, from clots, from developing heart attacks and strokes. It also helps protect your bones. Okay, it's one of the best ways to prevent fractures. I mean, if you look at who gets vertebral fractures in their spine, thoracic spine, lumbar spine, hip fractures. Okay, it's going to be postmenopausal women. Okay, it's not going to be premenopausal women. It's not going to be women who are younger. It's going to be women who are older. Okay, and this is the main reason. Testosterone also helps reduce risk of breast cancer in women. Okay, and it also helps with bone health and with brain health. Okay, progesterone serves as an ancillary, but if you ever take estrogen, you need to have progesterone in your system too to reduce the risk of having uterine lining issues. So if you don't have enough progesterone and you take an estrogen, your uterine lining, the endometrium will overgrow, and there's technically a risk of increased cancer of the uterine lining, uterine cancer, not breast cancer, uterine. None of these actually increase your risk for breast cancer. Okay. Now, of course, if you've had estrogen-sensitive breast cancer, you're not a candidate for estrogen right now. Okay. I mean, we still use common sense here. Even though it doesn't cause increased risk of breast cancer, we don't use it if you have an estrogen-sensitive cancer, a breast cancer. Okay. All right, Tom. Your question is my thoughts on hyperbaric, acupuncture, sauna, cold plunge, red light, ozone. Okay, so let's see. Hyperbaric can be useful for endothelial dysfunction. Okay. You have to be very careful, though, if you have mitochondrial dysfunction, because you're using an oxidative therapy, which is what hyperbaric oxygen is, and it can damage mitochondria further if you already have a mitochondrial compromise. Okay, acupuncture I think works well for pain. It's an alternative treatment. I mean there's some potential therapy for stimulating the vagus nerve, but you can do that other ways. However, I don't think it really would help anything beyond pain relief for the most part. Sauna could be helpful potentially for mitochondria, but it would be horrible in the hot room. Would be horrible if you have dysautonomia, POTS, or excess histamine or MCAS, because it's going to set those off. Cold plunge may be helpful. It's called a hormetic mechanism. You're basically producing a mild stress to induce a bigger antioxidant response. However, if you're already chronically stressed and have increased oxidative stress, it may just cause an increase in sympathetic activity without giving you any of the benefits. Red light therapy I like. I would actually prefer more infrared or near infrared therapy over red light therapy because it has deeper penetration. There is some benefit to mitochondria potentially if you can get the light to get to where it needs to go. Okay. Ozone therapy really has no medical uses whatsoever. It has actually a lot of potential complications. One of the big ones is a gas embolus, okay, because ozone prefers to be in gas form. And just because you put it into a liquid or into your blood doesn't mean it wants to stay a liquid. It could turn it back into a gas. And a gas bubble in your blood is not particularly a useful thing to have. The other problem is that as soon as ozone touches anything, it turns into hydrogen peroxide when it combines with water, okay, which is there's plenty of that in your blood. And while I understand the thinking behind it, that it sterilizes your blood or so, but really what it doesn't really do much in terms of that, and it introduces an extra oxidant into your blood. And again, I don't think that that's a great idea if you have a mitochondrial dysfunction already, okay, because we're already having trouble dealing with oxidants currently in your body, and you're adding additional oxidants. If you already had the antioxidants in your body to deal with it, then then it wouldn't be as big of a deal, except for the gas stuff, as I told you. But yeah, that's kind of how I feel about these therapies. I hope that answers your question. I know I have a bunch more questions, but we're kind of running low on time here. We're past 11. Let me take a look at which question I want to answer next. I'm going to try to pick somebody who hasn't asked the question yet. Timmy, regarding Dr. Lambert, you can have him contact me, okay? I'd be happy to talk with him, Timmy, but I have no way of finding out how to get in touch with him. My email is available in a bunch of different areas. So if you guys need to contact me, it's there, okay? Or if a doctor needs to contact me, it's there. No, we already did, Angela, but I will answer that question for you real quick. Yes, I am able to treat international patients. I do treat international patients all the time. So as long as you can come to the U.S., we'll take care of you, okay? I'm trying to find somebody who has not asked. Here we go. Philippe. What type of vaccine injuries are associated with the J&J COVID shot? So all of the, luckily J&J got pulled. It was pulled from the market. That was one of the few ones that was antigen based, because the other vaccines are mRNA based. That is, that our body makes the spike protein. J&J put the spike protein in there already into the vaccine. The biggest things that it's associated with is clotting, okay? Heart attack, strokes, clotting. There's also a higher incidence of myocarditis and pericarditis. It seems to attack the heart more. All these companies are immune from prosecution as part of the deal of making these vaccines early and quickly. And yeah, it's a big part of this this vaccine, unfortunately. But they recognized that there was a problem and they pulled it from the market. I'm going to conclude here. I know we have some more questions in there, but unfortunately, I can't continue forever. And it is a Sunday, and I'd like to take some time to rest myself. I will see you next month. If you're part of my paid community group, you know how to ask questions in there, okay? And that's the longcovidfamily.com group. If you want to sign up, I'm available there all the time to answer any questions just like this. I still can't treat you or diagnose you in the community, but I can do pretty much everything else. But if you're interested, so just come visit me at longcovidfamily.com and just sign up, and I can interact with you there all the time. Okay? Thank you so much, and